All right. A little adjustment. All right. Welcome in, everybody. So everybody's tuning in from out there. All right. All right. Hopefully, everybody was able to get in to see the preview of the case study that was put out on all the socials. So let's get into it. All right. So the case study was you were dispatched to a female who was described as being generally ill. Dispatch advised you that they were just complaining of a toothache. As you arrive on scene, you find the patient. She was sitting up in her bed. She was conscious, alert, oriented, 4, 5, and 6. Her airway was patent. She did complain of some mild shortness of breath. Her skin was pink, warm, dry, and she kind of described them. She was taking a deep breath while you were also taking lung sounds that it hurt to breathe. Okay, so again, complaining of that jaw pain and tooth pain for about 1 week and was describing what she felt like was heartburn and said that she'd taken some Tums, like an antacid, trying to ease it, but just really wasn't getting any better. She has no medical history, no known drug allergies, and really the only other thing going on is that toothache, along with the reflux GERD like stuff. Her lung sounds were clear and equal. Abdomen was soft, pliable, symmetric, and non-tender. Whoa, what happened to the focus? Okay, and it's back. Okay. Uh, and on the monitor, she presented with a sinus rhythm that just had an occasional PVC. Wow, look at the focus being all crazy. All right. So she had a sinus rhythm, just an occasional PVC. She was 94% on room air. BP was 140 over 90, just a little warm, 101.2, and her blood glucose is normal. 12 lead came out, even when the 12 lead was printed, those PVCs were so irregular that it wasn't actually captured any of the PVCs on the 12 lead. So as we went through and looked at all of our leads, there were no obvious ST abnormalities. Like I said, none of that ectopy actually got caught on the 12 lead, and it appeared to just be a sinus rhythm. So you were asked, what is your differential diagnosis? With that, what would the treatment plans be? And thinking of that, those occasional PVCs occurring in that, what would be the cause of those ectopic beats? All right, so let's get into it. Some discussions and comments that were held around the different socials included things like GERD, maybe an infection with that tooth, maybe it was acute coronary syndrome or relating into myocardial infarction, or maybe even costochondritis. Costochondritis meaning that inflammation of the intercostal muscles that attach your ribs into your breastbone. Okay, so taking that deep breath, it hurt, causing some pain. All right, so we kind of started thinking about acute coronary syndrome that putting these two together. Okay, so through the differentials with no history and kind of the presentation starting up here, a week ago, and then it kind of started getting into the neck and difficulty in breathing, and then just some discomfort in the chest. All right, so we did a 12 lead. Nothing showed up in the 12 lead, so we can kind of start ruling that out. And the pain she was kind of describing the chest was lower and tender, and just saying, kind of the Tums sometimes made it better, but it was just still staying there. And again, started up here and kind of started working down towards the chest rather than chest working its way up. Okay, so kind of going to that presentation order too. We kind of went through and ruled out acute coronary syndrome as well. Okay, so we did a 12 lead, kind of got a good basic pre-hospital cardiac workout, and nothing really was throwing major flags there that we were really getting into um, some acute coronary syndrome. And yeah, throwing out that flag there, that the PVCs can become a distractor, and absolutely they could. Okay, so when we start seeing those PVCs or ectopic beats, a lot of times with those, we're not even necessarily treating anything with the ectopic beats, but those are just kind of a indicator, like, hey, a cause for a warrant to do a little bit more detective work. And then with costochondritis, we can't necessarily rule that out. Okay, so taking it hurts to take a deep breath. The things we could maybe ask a little bit more is specifically where does that hurt at? Is it more along the sides? If it was over there, then that's just kind of chest wall pain. Or costochondritis is right around that breastbone because that is inflammation of those ligaments that are attaching the intercostal muscles to the breastbone. So generally, right around in here is where that pain will come while it hurts to breathe. Okay, so still a possibility there. With GERD, no history of it. Start asking those questions. Any type of fatty or acidic foods that we can work on our way to ruling that out. And then the Tums didn't really do much for her, so we kind of start ruling that out possibly. And then we go with infection. All right, so the patient um, had some tooth pain. Stated that she was not going to a dentist, had never been going to the dentist, and yeah, comments coming in. Yeah, fever, infection. Yeah, she was febrile, so we can kind of keep this in our back pocket too, keeping maybe this in the back pocket of where we're going at. So we're kind of leaning more towards this side, which could, if that was the thing, that could infection could cause costochondritis. All right, so getting this into being March Madness month, this was leading into what's known as Ludwig's angina. Okay, Ludwig's angina is, we hear the phrase of angina, we start thinking of chest pain. Okay, but it's not really acute coronary syndrome chest pain. It is pain that is more in the mandibular area. So it is in the floor of the mouth in between layers within the jawline that become infected from a bacterial infection. And most generally, always that's attributed to an impacted or rotting tooth. Okay, so building out from that history of that tooth pain, not seeking any treatment for it, kind of throwing some flags of you have an issue that a doctor could treat and you're not seeking any medical care, not taking care of it, and it's just getting worse and worse and worse. Okay, so that infection comes in the jawline, and you can see in the picture here some, depending on where your quality is and your contrast of this patient. So in this jaw, like if you were to look up and make a triangle down to about the hyoid bone, up around the jawline, and this triangle is where generally the sources of those infections occur. So they can have swelling masses one side or the other, and then it creates some redness that goes down because there's infection under the skin. Well, then it can get under that layer of skin, and then it can be spreading down through. So, like in this picture here, this patient who had diagnosed Ludwig's angina, there was quite a bit of inflammation around that jawline, and then quite a bit of redness going down through or out their chest area. So this tissue area starts to become infected, and it becomes sore, painful. But again, that triangular area right under the jawline is where most of that's going to occur. So if we can imagine looking at a dissection of the head here of in these areas where the swelling or infection can occur. So it gets in between these different layers. And what really becomes the most alarming thing for us is the fact that this is, another thing though too, this is another significant form of cellulitis. Okay, so inflammation within those different layers throughout the cells. So within these different spacings and pockets, that infection starts to occur, building out pus, different fluids, then inevitably it can get in here and start pushing up the tongue. Well, knowing that the tongue is our number one airway obstruction, it starts pushing up the posterior side of that tongue and can ultimately occlude the airway. Okay, so just think of relation to epiglottitis in kids of you know, swelling of that airway and the oropharynx closing off the airway. This is very much a life-threatening emergency as well. That pocket develops, significant pain, fever, so on, pushes up that tongue and includes the airway. So the symptoms you're going to see is obviously the swelling. So you may have like again in that mandibular triangular area, have that swelling maybe on one side or the other, or redness, tenderness, tooth pain, airway obstruction, and then we have airway obstruction, tongue displacement, dysphagia, swelling. So all that is going to inevitably cause some difficulty in breathing or the sensation of difficulty in breathing. With that dysphagia just hurts to swallow. So they may have excess salivation of just drooling, similar to that pediatric patient with the epiglottitis. And then pain, fevers, and chills from that nasty infection causing all these symptoms with that fever, aches, chills, and then pain going in around the tooth, the jawline, and then as more area and tissue becomes infected, so does that pain and radiating symptoms. So treatment for us in the pre-hospital setting is going to be recognition of this. Okay, so we, inevitably we'll run those calls. Well, I have toothaches, I have tooth pain. Like, okay, sometimes those are emergencies and sometimes they're not. But when it gets to this point that there is masses and the tongue is being displaced and moved, and there's potential airway compromise, that is indeed a very much a life-threatening emergency. Okay, so basic supportive care of being cognizant of it, detecting it, recognizing it, or suspicion thereof. Provide oxygen as need be. Humidified oxygen has been shown to provide those patients some support rather than really just drying out everything and irritating. Because remember, this is very sensitive tissue that's in here, so we don't want to cause any more inflammation or irritation of maybe like the oropharynx or the nasopharynx, anything that's going to make that passageway even smaller. And then the big thing is, at the hospital, IV antibiotics, and really just kind of going in and focusing on the source of that infection. So that may cause for a dental surgery to where they're going to actually extract the tooth, or even if it gets into more of the bone, that can go into ENT surgery, dental surgery, quite substantial surgeries to get rid of that source of infection to prevent ultimately the airway closing off. So again, just focus on the basic treatments of it all, supportive care, providing oxygenation, making sure that their airway remains patent, that, with the excess salivation may require suctioning. And then, there are rarities of prophylactic intubation. Okay, so in the field, if they are in significant distress or it is closing off the airway, that would potentially warrant getting aggressive with protecting that airway. But generally early on detection, recognition of it to get them to an ER to be able to begin those IV antibiotics and get rid of the source of infection within the body. So thanks everybody for tuning in today. So we went over Ludwig's angina. So remember that general source is an impacted or infected tooth. That infection begins to spread. And then we also remember that any infection that's getting into the bloodstream can cause a whole cascade of other complications. Now, why it may have caused pain in the chest, that's not necessarily attributing to acute coronary syndrome or myocardial infarction. And then with that infection going out in there, patient had infection, slight hypoxic, two main big attributing factors to that ectopic beat of PVCs. Hypoxia infections are big culprits of causing those PVCs. So just something to kind of keep your head open on. All right, everybody. Thank you for tuning in and take care.